shown about our first webinar occurred about 1 month ago on sinus node dysfunction and just an introduction to a patient with a bradyarrhythmia. These webinars are sponsored by Medtronic, and the idea of these webinars are to really increase the awareness, treatment, and improve the treatment of bradyarrhythmias and pacing across the world. These webinars are mainly designed for sort of low and middle income countries, and in places where cardiac pacing is not so much readily available. And so we have a string of sort of international guests that are speakers that we've lined up over the next few months. So without further ado, I'm going to introduce our two speakers today. Our first speaker, in fact, couldn't make it in person, but he's kind enough to send a pre-recorded session, so we're going to listen to that. It's going to be given by Professor CP Lau. Doesn't need much of an introduction. He's a very well-known cardiac electrophysiologist. He's the honorary clinical professor of the Department of Medicine at the Queen Mary Hospital in Hong Kong. He's the past president of the Hong Kong College of Cardiology and also the World Society of Arrhythmias. And he was the 2019 president of the Asia Pacific Heart Rhythm Society. So we'll listen to his pre-recorded session, and that will be followed by we'll introduce Dr. Naeem Shoaibi. We in person a bit later. He's kindly going to give us a talk in person, and then what we'll do is we'll hold the discussion and questions till the end of the webinar, and we really invite the audience to ask questions freely, and we can have an interactive discussion sort of at the end of the meeting. So I'm looking really forward to it. So Oscar, would you want to bring up his presentation on device selection? Thanks very much.
Good morning. My name is CP Lau from Hong Kong, where I am an honorary clinical professor of the University of Hong Kong. I'm also a past president of the WSA. It is my privilege to be invited to give this topic, device selection for bradycardic pacing, using a case-based presentation. Before I start, I would like to congratulate Professor Ali Otto for putting together such a good meeting. Bradycardic pacing is no longer simple in a matter of device choice and lead location. Traditionally, we place it in the right atrial appendage and somewhere in the RV apex or in the mid-septum region. However, for preservation of left ventricular function, now we tend to have the right ventricular lead paced just below the his or at the his level, the so-called conduction system pacing. To prevent atrial fibrillation, it is possible to pace in the Brakman bundle and a combination of both. Nowadays, we also have leadless pacing capable of delivering in a VDD fashion in the right ventricle or in a dual chamber fashion. These are made possible these days with advances in cardiac pacing, leadless pacing, conduction system pacing, and Brakman bundle pacing. I'm going to illustrate the practice using in AV block and also sinus node disease. The first patient is a 69-year-old in the year 2017 when he received a VVI pacing for slow atrial fibrillation. In addition, he has diabetes, hypertension with aortic embolism secondary to atrial fibrillation. He complained of shortness of breath on exertion and with 100% of right ventricular pacing. These are his left ventricular ejection fraction over time. Now from 59%, it dropped to about 42% when he was referred to my center. And his left ventricular and diastolic volume has increased. This is his 12-lead ECG showing a classical pacing and a wide QRS complex showing the left bundle branch block and a negative inferior axis suggesting pacing in the fall of the right ventricle. I always liken VVI pacing from the apex to left bundle branch block, and you can see the similarity of the left bundle branch block EKG and in this example of left bundle branch block. As composed in another patient, the left bundle branch block-like fashion of right ventricular apical pacing. We have shown, and others have done so as well, that this induces mechanical dyssynchrony, not only between the left and the right, but also the right ventricular and left ventricular segments of the ventricle. This was a study using tissue Doppler by my colleague, Dr. Yu, and we used tissue Doppler to characterize the activation of different parts of the left ventricle, the mechanical activation. You can see that with RV pacing, you can see there are wide disparity between different sites of the activation mechanically of the ventricle, but after CRT with a lead in the posterolateral vein, we see a more uniform contraction. Right ventricular pacing induced cardiomyopathy, or PICM, has been recognized for a long time and have been variously published. This is an example from our center that the new onset heart failure in right ventricular apical pacing for complete heart block is dependent on the QRS duration, and 165 was determined in this study using the AUC curve. And there is also the mechanism involved, which may be a decrease in perfusion of certain part of the left ventricle when they are tested on the Valium stress test. And in our patient, he has a very wide QRS complex and with a prior diabetic and hypertension, making him susceptible to pacing-induced cardiomyopathy. This is the new guideline on what constitutes PICM. The frequency of PICM with transvenous pacing is about 12% in retrospective series by Dr. Sumner and his colleague in the meta-analysis. The incidence depends on the definition of PICM and the follow-up duration. The objective definition of PICM is more than 10% reduction in LVEF from an LVEF which is 50% P-pacing, and RV pacing is more than or equal to 20%, and there are no alternative causes. This is the guidelines at that time without is a class 1 indication, and these are basically based on observational and meta-analysis that in patients with a CIED with a decline in LV function or worsening of heart failure symptom attributable to substantial ventricular pacing, CRT with biventricular pacing is recommended to improve the LV function and improve heart failure symptom. And is a 2B if conduction system pacing is used to upgrade such cases. This is what we did in this patient. We with the RV lead here, and we go to the coronary sinus and identify a posterolateral vein, and successfully put in a quadripolar lead here. This slide shows the ECG after the CRT upgrade, showing a significantly shorter QRS duration from 200 to 140 milliseconds, a change in the axis, and a very narrow, relatively narrow QRS complex. These are the results. The CRT upgrade, we use a Medtronic Perceptor quad pole CRT-P. The atrial port is plugged, and we use the old RV lead into the RV port and the new quadripolar lead into the LV port. After the CRT upgrade, the exertional dyspnea improved, and you can see that the ejection fraction has now recovered to 54% along with a reduction in the left ventricular end diastolic volume. After the publication of the HRS guideline, a randomized controlled trial known as the Budapest trial has been published. This is a study randomized study in heart failure with PICM. They are upgraded to either CRT and measured with heart endpoints. There are 360 patients in this study with heart failure and right ventricular pacing of more than 20%. And patients with heart failure with RV pacing more than 20% and a QRS duration of 150 milliseconds or more are being involved. Upgrade in a 3:2 ratio and assessed by the composite of death, heart failure hospitalization, or less than 15% LV and systolic volume reduction. These are the results. After an upgrade to a CRTD in this institution, the primary endpoint is of worsening heart failure was reduced compared with the ICD only arm. There are reduction in the death and heart failure hospitalization, and there is no significant differences in the procedural or device complication and a trend for a reduction in VT and VF. These are the data shown on the left-hand side as a time-related plot. The outcome are significantly less in the CRTD versus the ICD arm, and the same going goes with 6 months and a 12-month assessment. My second case is a patient with moderate coronary artery disease. He is 66 with exertional dyspnea for 6 months. His ECG was performed incidentally prior to BPH surgery, and they saw right bundle branch block, a very prolonged PR interval, and Mobis type 2 heart block. And his echo LVEF is 74% with an LVN diastolic diameter of 4.7 centimeter. This was the EKG showing a wide QRS complex from right bundle branch block and intermittent drop beat with the P wave. In this case, he's very likely to dependent on pacing to a large extent, and we have planned to implant a conduction system pacing lead. It was a Boston Scientific accurate MRI, and the longevity leads to both the ventricle and the atrial area. This was achieved. In this case, you can see that the left bundle branch area pacing lead was inserted with the angle at the site of the right side of the ventricle. This was on the right-hand side of this electrogram. The QRS with a wide QRS of 180 milliseconds was observed, and after left bundle branch pacing, there was a significant shortening of the QRS duration, along with the LV activation time in V6 of 80 milliseconds. This slide shows you the EKG before and after bipolar pacing. On the right-hand side, they show the V1 showing right bundle branch block and with a wide QRS complex of 180 milliseconds. On the left-hand side, on the right-hand side, using bipolar recording, you can still see the suggestion of right bundle branch block in V1, but a significantly narrower QRS duration. An improvement of the right ventricular bundle can be in part achieved by using bipolar pacing with anodal capture of the right side of the septum and possibly the right bundle. Can we use left bundle branch area pacing lead for permanent bradycardic pacing? This is taken from the guideline from 2023 HRS, APHRS, LHRS, CPP guideline. If one consider an anticipated RV pacing of more than 20 to 40%, these patients in those with chronic left bundle branch block is a 2A indication, need periodic assessment of ventricular function to detect cardiomyopathy. CPP is reasonable when the LVEF is less than 30, between 36 to 50% as 2A, and may be reasonable if LVEF is even normal. It's a 2B indication because there would be a substantial ventricular pacing. If the ventricular percentage of RV pacing anticipated is less than 20%, then RV lead placement in the usual RV apical or septum is reasonable if it's more than 35%, and it's a 2A indication. For LVEF, which is between 36 and 50% and not enough, not anticipated high percentage of pacing, either CSP or CRT are acceptable. In patients with normal LVEF, left bundle branch area pacing may be considered as an alternative to RV pacing lead as a 2B indication, but bi-V pacing is not indicated. This is a class 3 indication. Thus, in our case, we do use left bundle branch area pacing in these patients, which is likely to require substantial ventricular pacing. We do try to use an AAIR with a VBI backup in this patient because even with the prolonged PR interval, he was not that symptomatic, but RV pacing turned out to be about 21%. So we are utilizing that in normal LVEF, anticipated to require substantial ventricular pacing. It may be reasonable to treat CPP to reduce the risk of pacing-induced cardiomyopathy, and in this patient with a normal left ventricular function. My third example is a patient with recurrent syncope and intermittent heart block. He is an 81-year-old with coronary artery disease and with COAD and hypertension. And his left ventricular ejection fraction is 62%. The ECG showed a prolonged PR interval, right bundle branch block, and with intermittent 2-to-1 conduction. And with lengthy discussion with the patient, and given his age and his chronic obstructive airways disease, he preferred the leadless pacemaker system. This is the resting ECG showing right bundle branch block and a prolonged PR interval. And this is recorded when he has suffered from a period of syncope. And you can see that there was intermittent 2-to-1 conduction. Some of the data we show him is the long-term outcome of leadless versus transvenous pacing system. This is the Mkoko CED registry and the Medicare data between 2017 to 2018 with 9,000 patients being recruited in this study. The leadless pacemaker patients tend to have more comorbidities, but there was no differences in acute complication rate, and but significantly lower 6 months and 2 years complication rate, as shown on the right-hand side. The main complications of leadless pacing with the pericardial effusion, which is significantly higher at 0.8 versus 0.4%, which is age, female, low body mass index, and COPD predictive. The conclusion is that leadless pacing lead has a lower 31% lower rate of chronic complications. So in this case, we do implant a leadless pacing system, and we targeted in the mid septum because at that point we have shown that it may carry a lower rate of perforation in this particular man. The beauty of this device is that it has the ability to sense the atrium using sound, despite that the device is in the ventricle. So these are the accelerometer, and the accelerometer co-mimic the 4 heart sound, the A1, A2, A3, and A4. And this represent the A3 and the A4 represent the system to be sensed, and the A4 signal is the one that are targeted. This is taken from a telemetry printout of this patient, and the one parameter to look for is AMV pace, which is 91.8%, indicating that the mechanical part of the 4th heart sound are being sensed in 91.8% of the time, with V pacing only in 6.5% of the time. This is also taken of this patient have a backup accelerometer and is capable of switching from VDDR to VBIR when the patient exercises. This is the setting of 95 beats per minute for ordinary working, and the activity mode is activated. So this is example. This is recorded from a Holter when the patient is exercising, And when the VV interval shortened to 700 milliseconds, more than the 800 milliseconds of the PV interval because of mildly chronotropic incompetence, there is a switch to VVIR pacing. We have earlier published on these accelerometers in the right ventricle, and indeed this accelerometer seems to be quite related to the duration and the speed as well as the grade of the treadmill. And in this example, these are the heart rate from the accelerometer: 1.2 miles per hour, 2.5 miles per hour, and 2.5 miles per hour at 15%. Finally, it is important to also pace the atrium appropriately. This is a study by Mike Sweetney looking at the effect of ventricular pacing to minimize it to reduce AF in sinus node disease. When you pace the right ventricle, there is an increased instance of atrial fibrillation along with heart failure hospitalization. We did a study some time ago, randomizing patients to either with the endpoint of primary persistent AF and to atrial high rate episode and AF burden. We paced them in the low right atrium or high right atrium. This slide shows the randomization. The low septal right atrium pacing reduced the P wave duration, and also the atrial pacing is increased from 56 to 92% with overdrive pacing. At that time, the ventricular pacing is increased because of the overdrive, but was not significant between the two arms. In this study, we were slightly disappointed that there was no differences in the incidence of persistent atrial fibrillation between the appendage versus the septal pacing. But if you look closely, there was a separation between the appendage and the right atrial septum over time, although it was not long enough in this study to look at the differences. An alternative way to pace is in the Beckman bundle, and this was resurrected because of good data on some of the earlier work. This slide shows the site of the Beckman bundle, which is straight down from the SVC and then curling up as a bundle that traverses both the right to the left atrium. This was taken from an implant by my colleague, Professor Chair in our institution. Is a patient with 2:1 AV block with a prolonged AV interval of 200 milliseconds for conductor peaks, the P wave duration of 150 and the QRS duration 120 milliseconds. You can see there was a Beckman bundle potential here in this patient with 2:1 block. And again, from Professor Chair, you can see that the atrial appendage lead is the atrial RA lead is in the Beckman bundle straight down from the SVC, and there is a characteristic coil doubling back to reach the Beckman bundle in this example. So this is the EKG in these patients. They are YQRS complex with a prolonged PR duration, and after the Beckman bundle pacing, the P wave duration is shortened, and you can see they are all upright in the inferiorly oriented lead, and there was a significantly shorter PR interval and P wave duration. There are several cohort studies, not many randomized trials to address this. In this series by Margaret Infeld, they looked at a group of patients with pace in the Beckman bundle, right atrial septum, and right atrial appendage. There was a gradated outcome of a period of atrial arrhythmia free, although most of the patients developed atrial fibrillation over a course of 3 to 5 years. Dear Chairman, ladies and gentlemen, I would like to conclude. Nowadays, bradycardic pacing need to take attention to preserve ventricular synchrony is the trend for pacing both the AV block and also for other causes of bradycardia. If we need atrial pacing for sinus node disease, we need to consider future atrial fibrillation risk, and appropriate site selection of the atrial lead is essential. leadless pacing should be considered because it's useful for select patient group. Thank you very much for your attention.
I'd just like to thank Professor Chupak Lau in his absence for that excellent talk. I'd just like to introduce my co-chair today, Dr. Philasande Mkoko from Johannesburg. Pila, welcome. And I think what we'll do is you want to introduce Professor Shoaibi, and then we'll listen to his talk, and then we'll have some questions and questions at the end.
Great. Thank you very much, Ashley. Thank you to the World Heart Federation. I'd like to introduce our next speaker, Professor Naeem Shoaibi. He'll talk to us about pacing indications for AV block, which is very, very important, particularly for us. Thank you very much, Prof. I'd like to give the stage to you.
Okay, thank you. Thanks for the invitation. Thanks, Ashley. Thanks the team for the invitation. Let me share my presentation. Hope everyone can see my slide now.
Yes.
All right. So I've been given the task to talk about the pacing indication for the AV block. I'll make it less complicated. It will be more of an ACG approach. Go to the next slide. So what's the definition of the AV block? It's defined as a delay or interruption of the conduction between atrium and the ventricle. And that could be due to anatomical barrier or functional physiological impairment in the conduction system. And as you know, we divide them into different categories. First degree or second degree, it has two types, Mobitz type 1 or 2. Third degree or a special type, what we call the high-grade AV block, and I'll give an example for each. So for the first degree, I know that we have a different audience between resident students, general cardiologists. Some of those ECG should be basic for them, but we'll just go for the overview. For the first degree AV block, we defined it as, let me see if I can use my pen here. Can you see the markers?
Yes.
Yes, you do. So first degree AV block means there is a prolongation of the conduction between A and V, and that's represented in the ECG of the long prolonged PR interval of the more than 200 millisecond or more than 0.2 second or more than 1 big square. Always means the same thing. And always this is indicating in the conduction slowing of a conduction between atrium and the ventricle, and have a various cause. Could be a physiologic. That means any young individuals, if we put them in a good exercise test and use a very high heart rate, I can use a physiological delay in the AV node that resemble of a first degree AV block, or could be a medication related like a beta blocker, digitalis, or could be an ischemic cause or an infectious cause. So the other type, which is Mobitz type 1, which is a Winkie-Bach cycle. So that indicates there is a failure of a conduction of one of the P wave. But before that failure of a conduction, there's a setup of a prolongation of the PR interval before the blocking in the AV node. And that's when can we divide it into a different cycle. Usually in some cycle we call it 4-3 or 3-2. And this is number 4. The number 1 indicate how many P waves that's present. That's number 1, this number 2, number 3, and there's number 4, and a 3 QRSs. This is why we call it 4-3. And that could be a switch into a 3-2 Winkie-Bach cycle. This is 1, 2, 3 P waves for a 2 QRSs. So this is what we call it a Winkie-Bach cycle. And for us, if you're gonna look at the ECG quick, if you see something like a group beating like that, usually some of things that can cause a group beatings, and the most common is the Mobitz type 1 Winkie-Bach phenomenon. This is another example of Mobitz type 1. You have a conduction, failure of a conduction, but before the failure of the conduction, there is a prolongation of the PR interval. And the easiest way to look for the PR interval after the block and the PR interval before the block, and that's give you more visual illustration of a difference of the PR interval. This is the new example from Mobitz type 2, and usually when we say Mobitz type 1 and Mobitz type 2, the difference may be in the location of the AV block in the conduction system. But here, this is an example of a normal conduction, normal conduction, normal conduction, normal conduction. Then there is a failure of a conduction. But before this failure, there is no prolongation, no setup of loss of conduction, and that's giving a more of advanced disease in the AV node system. And that goes with the Mobitz type 2. And this is maybe an early stage for a complete heart block. And this is, we deal with those patients for indication for a pacemaker. I'll just give you some example. This is two different examples. This is a normal conduction of a PR interval, normal conduction of a PR interval, normal conduction, this is constant. And then we have a failure of a conduction of the QRS. But in this example, which is an example of Mobitz type 2, whereas the Mobitz type 1, we have a prolongation of the PR interval. So I'll just give you a more of a cake. This is the PR interval of 350, increased to 400, increased to 430 millisecond before the block. And there is a well-known physiological phenomenon. We call it the increment is decrement. So what does that mean? There is an incremental increase in the PR duration, but each time the decrement is less. Here, the decrement give you a delta of a 50. Here, there is another increment, but the delta of 30. So each time you have increment of the PR duration, but with a lesser amount. And this is a physiological phenomenon for a Wenke-Bach cycle. Third degree AV block, it can happen anywhere in the system below the AV node, at the level of the AV node if you have a complete transection, or if you affected the right bundle, left bundle at the same time, or maybe a digital conduction, a disease in the right bundle, left anterior fascicle, left posterior fascicle. And the way to differentiate between this and for the complete heart block, you need a very constant QRS to the QRS duration. You have to have P's more than QRSs. Plus, there is no relationship between the P and the QRS. And this is what we call it a phenomenon of a complete heart block. Remember, complete heart block doesn't mean the QRS has to be wide. It could be narrow, it could be wide. It depends where is the escape rhythm coming from. So far, I guess this is a very simple for a general resident for and medicine students. So what's a cause of AV block? So the most common cause of AV block is it's an aging process. It's a idiopathic fibrosis, but that could indicate at a younger age of underlying chronic cardiac disease, like ischemic heart disease, structural valvular heart disease, or post-intervention. Could be post-ablation or post-operative procedure, surgical or TAVR procedure. Or could be due to inflammatory infiltrative diseases. And this is why if you see a young patient, 30, 40 years old with a complete heart block, and there is no evidence of ischemia, really we have to look out why he has this disease in the AV node. And it's very common in our region to diagnose patients with a sarcoid. So yes, you can go ahead with the device selection, but you have to look for the cause. Lyme disease is a tick-borne disease that can affect the AV node, or could be drug-related, drug toxicity. All antiarrhythmics with von Wilms classification can cause AV block if it's over-toxic with the dose. Or could be due to electrolyte abnormalities. A common one is a hyperkalemia. So let's give a couple of examples. This is, I see P's more than QRSs. QRS to the QRS are dead regular, and you cannot make any relationship between the PR interval. Here, some people, they might say, maybe this PR is conducted, but for us, it will be a very short to have a PR conducted with this short of a duration in a conduction disease system. And this is why the P wave here is just marching through. This is an indication of a complete heart block. This is another example. This is patient with ST segment elevation, has a normal conduction PR interval, normal conduction, then a failure of a conduction. But because we understand what the cause of the failure in conduction, there is a PVC which cause an escape rhythm, and that disturb our definition where to know what is the conduction disease. But if you continue following, you have a normal conduction with ST segment elevation, loss of conduction, and then we can see here now more of a failure of a conduction. And this is an example of a complete heart block in setting of acute myocardial infarction. And this is patient treated with temporary pacemaker. And because it's very important to know that in the pacemaker indication, permanent pacemaker is indicated if no reversible causes. This is how complete heart block looks during cardiac surgery. Here's the heart beating, atrial beat, 4 beats, and then 1 beat in the ventricle. If we keep this cycle going, 1 beat, 2 beat, 3 beat, 4 beats of P wave, and then 1 ventricular escape rhythm. So if we look at the schematic approach of where is the AV conduction disease can happen. So in the 12-lead ECG, we start seeing the P wave and then PR interval and the QRS complex. But if you put an electrodes inside the heart, this is very complicated segment. It's not an easy. So we can able to generate and see atrial waveforms intracardiacally, indicate the Hess, which represent maybe the node or AV node area, and the V that represent the ventricular depolarization. And you know that the P wave starts way earlier than what we get in the intracardiac. So if you have a first degree AV block, that's mean prolongation of the PR interval. Maybe this is a prolongation due to from the atrium to the AV node, which is what we call it a PA interval, that we're not able to see it in the 12-lead ECG. Or you could have a disease in the AV node itself, or a delay in the Hess itself, or below the Hess before the ventricular contraction, or any delay in those segments can cause a prolonged PR interval first degree AV block. And if you look for the second region, which is the AV node, which we present in intracardially by AH interval, if you have a delay or disease in this segment, that can produce first degree AV block or second degree type 1, or could be if you have a complete transaction, then you'll have a third degree AV block. The third region, what we call the Hess region, if you have a disease in this segment, that again can cause first degree AV block, or you could have the two types of second degree AV block, Mobitz type 1 or 2, or you could have complete AV block. Digital disease below the Hess, what we call infrahessian, again can produce anything of those, first degree, second degree, third degree, or a fourth. So prolongation of the PR interval could be a very complicated. It's very hard to know in ECG where is the level of the block. And then we'll have an example like that. So we know what's the first degree, we know what's the second degree Mobitz type 1, failure of conduction with a prolongation before, or a sudden conduction with Mobitz type 2, or a complete heart block. And then we have an ECG like that, so it should show it 2-to-1 AV block. You have 2 P waves for each QRSs. But what is the level of the block? Is it goes inside the AV node or below the AV node? And sometimes it's very hard to know, but let's see and discuss a couple of options. And here in this observation of ECG, I need to get attention that the patient has normal conduction, short PR or normal PR interval, normal QRSs. Just keep mind on that. Second example of a 2-to-1 AV block, but this example are different. We have a PR duration, which is within normal, but the QRS are wide. So this is maybe give us a clue, where is the level of the block? Is it at the level of AV node or below AV node? And this is a third example of 2-to-1 AV block, but this time with a more prolongation of the PR interval and maybe a disease bundle with atypical right bundle. So if we have a phase 2-to-1 AV block, you cannot apply the maneuvers of prolongation of Mobitz type 1 or Winkelbach cycle, because you don't have enough cycle to judge. So with the 2-to-1, there is another maneuvers that we can look into it. And really you have to look at two things in ECG. Plus you can apply maneuvers. So in the ECG, you look at the PR interval. So if the PR interval is long, so the disease may be at the level of the AV node. So if you have a 2-to-1 AV block with the normal BR interval, really you cannot judge, but maybe the disease is below the AV node. So the more prolonged PR interval in a 2-to-1 AV block, maybe this is a safe ECG of a level of AV node blocking, not below the AV node. Second thing, look at the QRS duration. If your QRS duration is wide, you have indicated of a left bundle or a right bundle, that's maybe give me another clue. This is maybe the disease, it's more of advanced disease below the AV node. Again, this is not for sure. This is just some puzzle that we have to solve. And this is why we will have to apply the maneuvers. First, look at the BR interval. If the BR interval is normal, maybe this is not safe. If the BR interval is long, maybe at the level of the AV node is the block. If the QRS duration is prolonged, this is not safe. But if it's a normal, that does not mean a lot of things. So what's the maneuvers that we can apply? There's a couple of them. So basically, you need to change the autonomic system somehow to look what is the difference. I'll give you an example for that. Here, we have a patient with 2-to-1 AV block. We applied a carotid sinus massage. And what's a carotid sinus massage? It's just increase the vagal tone. And if you want to think the AV node is an anatomical structure with physiological phenomena that you can affect the physiological phenomena of the AV node. So with the carotid sinus massage, you increase the vagal tone. So that means you will affect the AV node. So that means if the disease in the AV node, you're going to make it worse. But if the disease below the AV node, that means you delay some conduction to the AV node, make sometimes for the below node structure to recover and have an improvement on the conduction system. And this is exactly what happened. 2-to-1 AV block, we apply the carotid sinus massage and the improvement in the conduction system. That means once I delay in the AV node, conduction improved. So I'm dealing with the disease that below the AV node at the Hess or infrahessian structure, which is not a safe block. Another example of exercise. So what does exercise do? It's increase the generation of the P wave from the sinus node, improve the conduction of the AV node. And then if you have a disease in the AV node, with exercise should improve. But if you have a disease below the AV node, that means you're inviting a lot of P wave and enhancing conduction of the AV node. And if the disease in the below the Hess, you'll create more plaque with exercise. Here, the patient with 2-to-1 AV block start exercising and I improve the conduction. So once I improve the conduction, that means I am dealing with a disease that block at the level of the AV node. This is another example. Patient with normal QRS, normal PR interval, but once he starts exercising and induce 2-to-1 AV block, that indicate the disease at the level of the below the AV node, because exercise invite a lot of P wave, improve the conduction of the AV node, and then if you have a disease in the Hess region, that will face a lot of P wave, more of the capability of the Hess, and this is why we induce 2-to-1, sometimes 3-to-1 AV block with a level of exercise. And again, this is not a safe AV node disease. And we can apply these maneuvers in a complete heart block. So if you have a complete heart block, as I told you, if I have a complete heart block, the disease could be at the level of the AV node, could be below the AV node, could be below the Hess. So you can apply the same maneuvers to understand where is the level of the complete heart block. This is an example of a P wave that marching through, and you have regular to the regular QRSs. And with the carotid sinus massage, so I did a carotid sinus massage here in the AV node. I make a more further delay in the AV node. Once I make a further delay in the AV node, if a disease in the AV node itself, I would expect worsen conduction. But here with the carotid sinus massage, I improve the conduction to 1-to-1. That means I make a good time for the bundle of Hess to recover, so the disease is below the AV node. Same example, disease below the AV node. If you give atropine, you increase the sinus rate, you improve the conduction through the AV node, but this is more of a block. So this is the disease is below the AV node, which is a not safe complete heart block. So let's give a couple of examples. This is a patient with 55 years old with fever, 3 weeks post mechanical mitral valve replacement, and he presented with a new first degree AV block. First degree AV block, as I told you before, it could be a physiologic, could be a pathologic. We see it a lot in ECG in asymptomatic patients, no previous surgeries, nothing indicate fever, nothing indicate infection. Then we pass it through. But after a recent cardiac intervention, always think about abscess that include area beside the AV node, and this is why they have new prolongation of the PR interval, and that could indicate an infection in the AV node area. This is another example of a patient, 54-year-old with muscular dystrophy, present with the ECG of a 2-to-1 AV block, and we know those type of diseases, they have a higher risk of AV node disease, and pacemaker will be indicated even if they are asymptomatic, even if they are no syncope, because this is indicate advanced involvement in the conduction system. This is just a reminder of another ECG of a complete block. You have P waves more than QRSs. QRS to the QRS is regular, and P waves is marching through. You cannot make a connection between the P's and the QRSs, so the diagnosis of a complete heart block. And this is another example of a patient that I could not see a good P wave, so indicate of atrial fibrillation. But remember, as a medical student, we've always been saying atrial fibrillation is irregular repeats. That means irregular QRSs. But here the QRS to the QRS duration is very dead regular. That's indicate patient with atrial fibrillation with a complete heart block. This is another example that we do not like to see, and that's indicate advanced disease. This is patient with the left bundle branch block. This is a V1 left bundle branch block, and then switch into right bundle branch block with axis deviation, alternating bundle branch block, especially in a setting of ischemia, indicate advanced AV node disease, and worrisome for that patient need a pacemaker, even if they have no symptoms, even if they have no syncope. So let's go more of a difficult example of what we can see here. If I can see this at ECG like this is how I analyze in ECG. I see here the first part of the ECG, we have a good conduction, then we have a big space that indicate maybe there is some conduction diseases. And when I look into that, I can see a P wave that's not conducted into the QRS. But why this has happened? So this patient with normal PR interval, normal conduction sinus rhythm conduction, and then we have an earlier peak, which is a PACs. So the PAC conduct into the AV node, and maybe if you have this schematic here, you have a sinus rhythm, and all of a sudden you have a PAC. PAC conduct into the AV node, but once in conduct, it reset the P wave, to reset the sinus rate, and keep the sinus rate a little bit slower. But even with the slowing of the sinus rate, this sinus beat is not conduction. And this is what we call it a phase 4 AV block, which indicate advanced AV node disease. And if you put it in a special schematic, the early PAC, as it's getting faster, it gives you a more refractory period behind it. And this is the refractory period of a conduction system. And this is why the PAC making prolongation of the refractory period, even this late coupled sinus beat did not conduct. This is an indication of advanced AV node. The PAC showed us that this patient has an AV node disease, and the pacemaker is indicated. So interestingly enough, I'll just go back. This is another example of a sinus beat conduct, sinus beat conduct, sinus beat conduct, sinus beat conduct, same conduction, and then all of a sudden you have a P wave that came early. So this P wave, PAC, it reset the AV node, even though the PAC did not penetrate and went into the ventricle, but able to generate a prolonged refractory period in the AV node. And in this just simple BAC cause all those block, and this is a phase 4 AV block, indicate an advanced AV node disease. That's need for a pacemaker. Does it only happen with the BAC? No. This is an example of normal conduction, sinus rhythm, then they have a PVC. This PVC caused a retrograde P wave. So this way PVCs came here, went to the AV node, to the atrium through retrograde space, and then make the sinus beat afterward is not available because of the engagement of the bundle, because of the right of the BVC, and it create another phase 4 AV block, indicate an advanced disease. And if you look, this is from the beginning, patient has a right bundle, has a left axis, has a bifascicular block. We know this patient from the beginning that he has an advanced disease in the bundle, but with the BVC able to demonstrate that even the other fascicle is not working properly. This is another example of a patient with a right bundle branch block, left axis deviation. We implement a cardiac sinus massage that's causing an AV node disease, and those AV node disease create a lot of block in the AV node with those all P wave. This again indicate advanced AV node disease that patients need a pacemaker. So what's the indication for pacemaker? It's very simple. It's the only difficulties that we have to make a diagnosis in ECG. So the class 1 indication for sure for complete AV block. If no reversible cause with or without symptoms, if patient has a 2nd degree type AV block, symptomatic Mobitz type 1 or type 2, or you could have exercise-induced 3rd degree or 2nd degree AV block in absence of myocardial ischemia or reversible cause. If you have a Mobitz type 2 with the wide QRS, even if no symptoms, this is indicate class 1 indication for a pacemaker. Class 2 indication that include asymptomatic Mobitz type 2. As we know, if there is no reversible cause, could not find the reason, most likely those people with that, they will advance to complete heart block. Patient with the 1st degree AV block and they are symptomatic, very prolonged, 280 millisecond, 300 millisecond, that could be asymptomatic from 1st degree AV block, that could indicate for a soft indication for pacemaker. Asymptomatic 2nd degree AV block. If we discovered in the EB study that they have a severe distal infrahissine AV block, then those patients need a pacemaker. What about chronic bifascicular block? So if the patient has 2nd degree or 3rd degree complete heart block or 2nd degree AV block, in advanced bifascicular block, they need a pacemaker. If I demonstrate bifascicular alternating bundle branch block, then this is need a pacemaker, or the bifascicular block has a 2nd degree of any type. With a chronic bifascicular block, if the patient, we do not demonstrate further block, but had a cardiac syncope that's worrisome, or if we did the EB study, we stopped doing EB study to understand the chronic bifascicular block. We always go with finding of ECG of AV block, or if the patient has a syncope. Sometimes we do it if patient had a syncope and we are not sure if this is cardiac syncope or something else. Studying the HV interval, if you have HV intervals very prolonged, more than 100, that indicate advanced disease and the patient need a pacemaker. But the chronic bifascicular block in a setting of a neuromuscular disease, then we go ahead even if there is no symptoms, because this is just a marker of advanced AV node disease. With this, I thank you.
Thank you very much, Prof. That was very nice. I think we'll open the floor for questions and some discussions, actually.
Yes. Yeah, so those who are attending, please, we want to make it interactive. So please put your questions in the chat box, and then we'll do our best to ask Naeem if you can answer that. Thanks, Naeem. That was really an excellent talk. Can I ask you a question, just to start off with? We see a lot of I'm just thinking, in particularly now in the low and middle income countries, we see quite a bit of sort of asymptomatic sort of Mobitz 1, Mobitz 1 AV block, asymptomatic, sort of middle-aged elderly patient, and we don't always have access to checking, where's the level of block? Is it infranodal, nodal? How do you manage? What would you recommend in someone who comes with asymptomatic Mobitz 1, sort of a high burden, and you don't have access to an EP study? What would you do there?
Right. So excellent question, Dr. Ashley. So basically for Mobitz type 1, first time when I see a ECG like that, or maybe most of the time we see this in a Holter monitor, we have to make sure what time was it. So if it's in the middle of the night where patients are sleeping, then I pass, I do nothing. This is a physiological. That's mean he had a good sleep. This is the only thing that it's indicate. But it's really not usual to have a Mobitz type 1 during the day, or patients who's going to doing activities and he has a Mobitz type 1. So this is why you are out of a vagal tone period. Then if you have a Mobitz type 1, if he is symptomatic, I will do nothing, but I'll try to do those maneuvers that we've talked to. Those maneuvers are very simple. Giving carotid massage, put him on a stress test. This is a very simple maneuvers, and that can help whether this conduction will improve by changing the hemodynamics or alternating the dynamics of the AV node. And that can give you an example of if the AV node improved conduction with exercise, I will do nothing. But if Mobitz type 1, I put him on treadmill, and with this stress test, I see more level of a block, that's indicate an advanced disease, and most likely it's a below AV node disease. So I don't take them to the AP lab. I'll just apply those maneuver. Good carotid massage, good exercise test. You can give the medication like atropine. That sometimes can help you to identify the level of the block.
Yeah. Yeah, thanks. That's quite useful. Pila, do you want to comment?
Just a quick question and maybe a comment as well. You emphasized a very important point, particularly in young patients presenting with conduction disease and heart block, that is identifying the etiology of the heart block, because it has implications sometimes on the device that one would choose. For example, complete heart block in someone with sarcoid would have an implication in terms of what device we'll choose, whether it's a simple pacemaker or should we be discussing a defibrillator?
Yes, correct. I have a quite young patients here in my practice. They present with the complete heart block, and sometimes Mobitz type 2 or AV block. And when we do the echo, we see no signs of ischemia, nothing. Everything looks normal. And for those, before we implant any device, we send them for the cardiac MRI to look at the infiltrative. And if we diagnose a sarcoid, and most of those patients here in my practice have been diagnosed with a sarcoid, so the selection of the device will be now the different games, because there will be advancement of the cardiomyopathy in those patients. This is why we implant an ICD on those patients. So definitely, conduction disease at young age, this is not a normal. So, and most common cause of a conduction disease, it is an aging process. Having said that, aging process is very different from region to region. And a patient with very poor diabetes control, very poor hypertension control, the definition of aging are different from a patient who has no diabetes, no hypertension. So even the definition of aging process is different. But at least those patients, they need to have some sort of imaging to rule out infiltrative diseases. Do I do ischemia workup for everyone? Not really. If a young patient, I don't know risk factor for coronary artery disease, I'll just go for the cardiac MRI. But for elderly, I have to make sure that the coronaries are fine, even if they have no signs of angina. Always I need to have some sort understanding of what is the coronary artery disease that are doing those patients. And there is a couple of patients that we diagnose with aortic stenosis. We know patients with severe aortic stenosis, they have a high burden of calcium. And you know what? If you know it is not far away from this infiltrative process, and you can diagnose patient with the conduction disease and a complete and aortic stenosis.
Yeah.
I can just recall, I mean, Pila and myself wrote up a paper on the causes of heart block under the age of, I think it was 55, Pila, and it accounted for about 15% of all our implants. So it's not uncommon that you'll get a patient with a sort of a younger patient where it falls outside of the traditional degenerative range. And I think you made an important point to look for underlying causes, because sometimes they're going to be some reversible and then some, causes that have some sort of management implications, like a patient with a sarcoid. So I think that's an important take-home message for the attendees today. I've got another question, maybe for Pila and Naeem. I mean, Professor Lau's presentation was a really good one, and he started off by commenting that the device selection is becoming very, very complex these days, because in the past, for brady pacing, we would implant an RV pacemaker, and that's it. These days, we're sort of faced with a host of different options, including leadless pacing, conduction system pacing, and then still, traditional RV pacing. So how do you guys, for plain old, let's call it heart block, degenerative heart block with preserved LV function, probably going to have a high RV pacing burden because of the patient's got underlying heart block. How do you choose between, what are you doing? Are you putting in an RV pacemaker, putting in a conduction system pacemaker, putting in a leadless pacemaker? What are your practice, and how do you decide which patient gets what?
Yeah. For me, at the moment, everyone gets conduction system pacing because the cost implications are pretty much the same. And they may be different when we talk about pacing-induced cardiomyopathy down the line when we're pacing the RV. In fact, personally, at the moment, I feel like probably everyone should be paced by conduction system pacing. But with that said, I think that whenever guys are doing conduction system pacing, they should select the patients appropriately. I think in my feeling, the ischemic cardiomyopathies and the ischemics don't respond as well with conduction system pacing when compared to the non-ischemics. So if you were doing cardiac resynchronization, if you've got an ischemic patient, you probably should send it to someone who will identify that this is not the right response. I should upgrade to something else. But everyone should do conduction system pacing, but we need to know our limits and identify the patients that are not going to do well to make sure that we send them to the appropriate people so they can get the appropriate device.
Naeem, what are you doing in your practice?
I think same thing. I think conduction system for everyone, but I see in electrophysiology field sometimes we contradict each other, because now we know leadless pacing, and there is some patients that prefer to go for leadless pacing. They don't want this scar, less risk of infection. So you have to really play the games. If a patient with a complete heart block, end-stage renal disease, and hemodialysis, I will not put a conduction system. I'd like to go with the less risk of infection. So I play it. It depends on the patient criteria. We have a lot of young female patients with the congenital AV block, and they reach an area, they still have a normal ejection fraction, and they went to the area of symptomatic complete heart block. They're going to go through their pregnancy and their lives. And when you talk to them, yes, I prefer a conduction system for them. But you know what? She will say, I want to enjoy my life. I want to dress up the way that I want. I don't want scar on my chest. We just go with the leadless pacing. So we have an options. So engagement of a patient of the option that we have, and what is the benefit and what the downside effects of each option, and it should be there. Maybe the future with the leadless pacemaker, and if we are able to get a good conduction pacing with the leadless pacemaker, I think maybe that's will be the new future for EP. Because if I remember, when you start leadless pacemaker, we always say we need the AP conduction. We need to put the atrial lead, we put the ventricle lead. And then once we introduce the single VVI leadless, everyone was happy, and now everyone is forgetting about the AV node conduction and putting just the VVI device. And now we have a leadless that's preserved the AV conduction somehow, and we're debating about the conduction system. So if the priority for the conduction system pacing, but then I'll do patient selectively, because I don't want to put the conduction system in a patient with a high risk of infection, and then we'll end up by a lot of complications. So this is why we have to play it patient by patient.
Yeah.
Fortunately for us, lately, the leadless pacing has sort of been prohibited by cost. The cost difference is 5 times for a leadless pacemaker compared to the old traditional pacemaker, which in a way is not accessible for our patients at all, in both private and in the public sector. So that has made that selection easier for us because we can't afford it. Once in a while, we've had recurrent device sepsis and lead problems. And I think those are the few patients, actually, we've had to put in the leadless pacemaker. And after motivation for hours and days, yeah.
Now, I'm glad to hear you're both early adopters of conduction system pacing for Brady pacing with preserved LV function, because I think that the data is starting to suggest that probably is better than RV pacing. But I think we don't really have the full data yet, randomized data comparing RV pacing and conduction system pacing for preserved LV function for bradycardia. And I think the most important take-home message is, for heart block, you need to pace the patient. To get the pacemaker in. And I mean, I remember the first patient who received a pacemaker from Sweden. He survived until the ripe old age of 82 with heart block, and didn't develop a tachycardia-induced pacing-induced cardiomyopathy. So I think, in places in low and middle income countries where the expertise might not be available yet to implant leadless or conduction system pacing, I think the most important thing is to get an RV pacemaker in there, and that patients can really do well, because the pacing induced cardiomyopathy percentages, I think, are a little bit inflated, according, in my opinion, and I think a lot of people will still do well. So I think we're still awaiting the full data on conduction system pacing for that sort of group.
Yeah, correct. I actually just need to ask. I really. A patient doesn't read the guidelines, does not read papers. They want to have a safe physician who help them in a decision. So even so we have a long safety data of RV pacing. So it's not the time now to say this RV pacing is not good anymore. I have a 92 years old whose creatinine GFR is less than 30. He's not in an area of a dialysis yet. Came with a complete heart block. Should I do conduction pacing, and maybe to make sure everything is good, I'm gonna give him contrast and jeopardize his kidney, or just keep it simple, go for RV pacing? So really, you have to make, there's a lot of variables, and those variables it affect my decision. Those patients, I'll just go straightforward RV pacing, go septal as much as I could. When I'm gonna induce pacing induced cardiomyopathy in this patient, it's better to induce it by the contrast, just to make sure that my lead in a good position. This is why, as I think, patient selection, you need to have, there is a lot of variables.
Yeah, I agree. Okay, I think we've gone over quite a lot over time, so I think I don't see any further questions in the chat line. So I think we're going to have to, end it here, Pila. But so thanks again for Naeem. Thanks very much for agreeing to give the talk today. That was a really excellent talk. I think your ECGs and your examples really summarized the topic very well. You showed some good examples, and I think just sort of stressed the indications for the attendees. And then for Professor CP Lau, in his absence, we want to thank him for that excellent talk as well on device selection. So thanks very much, and we hope you had a good session. There'll be these webinars are going to be continuing in the World Society. Then the next series of webinars are going to be on more practical aspects for cardiac pacing, and practical aspects about how to implant the different types of pacemakers. So I hope that the attendees will continue attending these webinars. And just finally, I'd like to thank the World Society of Arrhythmias for hosting these webinars, and also for Medtronic for sponsoring these events. So thanks very much, and good morning, good evening, and good afternoon wherever you are in the world. Thanks very much.
Thank you.
I appreciate it.
Bye-bye.
Thank you.
Bye-bye.
Bye.